typical end-stage renal disease patient has 5 to 6 chronic conditions. It's unheard of to just have end-stage renal disease. It's typically diabetes and hypertension are what lead to end-stage renal disease.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management for Professionals. In this edition of the Business of Healthcare podcast, we go back to the West Coast. Today, we're exploring a topic that impacts over 30 million people in America, and one that most of us are not very familiar with: chronic kidney disease. We're fortunate to have Misha Palecek, the Chief Development Officer for DaVita Kidney Care. Misha has been a key driver of care transformation for one of the largest kidney care providers in the United States. Welcome to the podcast, Misha.
Yeah, thanks for having me, Bob.
Well, most people, they may not know about DaVita, but you're a large public company with over 65,000 employees. You've been there for over 15 years, and you've seen a lot of change. And you've been highly recognized for your leadership within the company and also in the healthcare industry. And we always like to touch on the personal background. So what brought you to California?
Yeah, so I'm a first-generation American. So my parents came from the Czech Republic, from Prague in 1969. They actually have an amazing story that we don't have enough time to get into today. But my father came to school in California. My mother actually escaped the communist bloc back then, and then they got political asylum here and sort of lived the American dream in ways that inspires me still to this day. And then I was born in California as a result of their move out here to the United States. And they're probably the most, they are the most patriotic Americans and grateful Americans even in these days in this world that you can ever hear from. So it's always nice to go and talk to them and have a dinner with them to hear their gratitude.
Well, we don't usually get to choose our parents, and it sounds like you won the lottery when it came to that, and having parents that can influence you. So you were born in California, and you're native.
Yep.
That's probably unusual nowadays as well.
That is also highly unusual. Yes.
I'm in Texas. I've been here for 40 years, but not native. I didn't get here soon enough, but I'd claim to be one if I could.
Yeah.
So tell me, continue on with the story. Where did you go to school, and how did you get into this business?
Yeah, so probably my interest in healthcare started in high school, actually. I had an amazing biology teacher. We lived close to Stanford in my public high school, and in this AP biology class, we got to dissect sharks, and we looked at a cat, and we actually got to look at a cadaver, which I thought it was amazing as a high school student. And so I started getting quite interested, and I grew up in this world, this technology world in the Bay Area, and everyone was interested in computers at the time. And I thought, wow, isn't the most amazing computer the human? And how does the human work as a computer? And so I ended up going to Stanford. I was a human biology major and decided not to go into medicine as medical school, but always knew that I wanted to do something in healthcare. And then, unfortunately, it's about 11 years ago now, I'm one of 3 brothers. My older brother passed away when he was 37 years old. He was super young. He had a staph infection, and I experienced 21 days in an academic medical center with 12 different specialists that were following his care, trying to figure out how to save his life, and just the sort of fragmented care and how hard it was to navigate as a family member what was happening with him and how we could try to solve the problem. It was an unfortunate experience that then has led this drive towards we really need to keep working hard, all of us, to transform healthcare, because it's just not right when those types of things happen.
Yeah, we've had a lot of different people on the podcast, and we've all agreed that we need to make improvements to healthcare. We've had some people have written some books on that topic, and the stories of things that go wrong are long and many. There's so many things that need improvement, and you just can't fix everything at once, but you can start to focus in on certain areas where you think you can make a difference. And, the care models that are used today, some of them are status quo. They've been around for a long, long time. So we really applaud those who take a fresh, innovative look at trying to make things different, make things better. So how did you end up at DaVita?
Well, I was actually a management consultant before I came to DaVita, and it was just out of a blue phone call from a search firm that was looking for someone with a consulting background with some healthcare experience. I was doing healthcare consulting to come to DaVita. It's been just a fantastic 15 years where I ended up being an operator in Northern California, managing dialysis clinics in the Northern California area. And then I had the great fortune of starting, you might have heard of it, Bob, but a small primary care startup called Paladina, which still exists today. And then I worked for about 4 or 5 years with Healthcare Partners in the managed multi-specialty group practice, in particular in New Mexico. I worked with some of the physicians out there. And then I returned back to DaVita Kidney Care and have been with DaVita Kidney Care for the last 4 or 5 years.
So I never want to assume that people understand what a company does because, like I said, I'm kind of status quo. And my first thought was when I'm familiar with DaVita, it's been around for a few decades. My first thought was that you guys manufacture dialysis equipment.
We don't do any of the equipment at DaVita, but what we do is we care for over 200,000 patients who have failed kidneys. The term that we tend to use is ESRD, end-stage renal disease. That's when your kidneys have failed and you have to have dialysis in order to sustain life. And so we have over 2,500 dialysis centers and a very large home program where patients do dialysis at home as well when we're caring for patients with end-stage renal disease.
Okay, just to expound on that a little bit, because I would flunk the test if you asked me what's involved with dialysis, who gets it, where they get it, how long does it take, kind of paint the picture what the day in the life would be when somebody would need to start to have dialysis and how long that would continue. Kind of frame that out for us if you would, Misha.
Yeah. So let me frame it out sort of across the entire journey that a kidney care patient has, which is your kidneys start to, for some people, will start to degrade the function. Actually, most of us, if you went off and got your kidney function tested, it would not be functioning the same way that it was when you were a young kid. And some people progress to late stage, it's called CKD, chronic kidney disease, where you start to have to see a nephrologist where they start to care for you. And unfortunately, some of those patients end up in end-stage renal disease, which is when you actually need renal replacement therapy. There's different types of renal replacement therapy. Probably the one that nobody would argue, if any of us had end-stage renal disease, then we would want a transplant. That's the one that everybody is hoping for. And of course, we have a shortage in kidney organs, and so not everyone can get that. And so if you can't get a kidney transplant, then there's different forms of renal replacement therapy. One is to do it at home, so you can do dialysis at home. About 12 to 13% of patients in the United States do their dialysis at home. And then the rest of them do it where they come 3 times a week into a DaVita or another provider's dialysis center, and you have a dialysis run for about 4 hours. And so what happens is you get, needles stuck into your arm typically, and the blood comes out of your body. It goes through a machine, it filters out the toxins, and then comes back into your body. And you do that run for about 4 hours, and at the end of that, you get to go home. But you have to continue to that in order to sustain life.
That's a good insight there. I never realized that it's that frequent in a week and that many hours. That experience has got to be a tough mental thing to run through as well. And I'm sure there's other things that might be in place, other comorbidities might be in place as well in these situations. And so to have that experience, are patients today, are they getting the kind of treatment that they need? Are there ways to improve that? Is that kind of your mission there?
Yeah, absolutely, Bob. When we were talking about fragmented care earlier, kidney disease is a perfect spot for us to be doing much better than we have in the past. And in particular, one of the problems that we're trying to solve at DaVita is that 50% of patients that end up having to do renal replacement therapy or that end up in ESRD had no idea that their kidneys were starting to lose their function until they end up in a hospital with an acute exacerbation, and the doctors tell them, "I have bad news for you, Bob. Your kidneys are no longer functioning," and they have this traumatic event where now their life is completely turned upside down, and they tell you now you have to do dialysis for the rest of your life,
oh, wow.
or until such time that you have you have a transplant. So it's very traumatic. And so what we're trying to do, so as you mentioned at the top of the podcast, about 37 million Americans have some stage of degrading kidneys, 1 in 7 of us. And the key to doing this better in the US is, in the United States, is to just raise awareness. And let me just, to bring this to life with audiences, I do the following, which is, how many people, I ask the question, how many people know what their blood pressure is, and or how many times have you gone to a primary care visit and not had your blood pressure taken? And of course, everyone mostly says, I know what my blood pressure is, and if you're hypertensive, there's some care plan to try to address it. Well, back in the 1970s and 80s, that wasn't the case. Hypertension was known as sort of the silent killer that was asymptomatic, and over years and decades of time, it would lead to really bad things. And so then I would ask you, Bob, do you know what your GFR is, which is a glomerular filtration rate? Right. And the answer typically is nobody knows what it is. It's a very simple blood test, and it would tell you what the function of your kidneys are. And that awareness of kidney disease, so then we can intervene, nephrologists can start to intervene and slow the progression, is one of the keys that we need to get to improve care.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
Well, it's on TV. I just get tired of all these pharma commercials. They're kind of cute, but what's your A1C? I mean, people didn't know what their A1C was related to their blood sugar and things of that nature. And so some of this awareness factor has got to be a key idea. Is there anything at all? I'm sure that population management, looking at a large population, trying to get them educated, trying to get them aware. Like, for example, I feel like I'm a healthy middle-aged person. How would I know if I had kidney symptoms? I know what my kidneys are supposed to do. They're supposed to process about 200 quarts of blood and filter that and give me about 2 quarts of urine. And so my only test would be is that if I have urine coming out that's okay, I'd be healthy. I wouldn't think of anything else. Are there other things that you educate people about? Like on colon cancer, they say, there's tests you can do and hypertension, et cetera. Is there anything, a barometer of indication that you advocate?
Yeah, that's exactly the problem, Bob, which is kidney disease is an asymptomatic chronic condition. And so there's really nothing that you would be feeling, in your day-to-day life that would indicate, my goodness, my kidneys are starting to fail me and that's why 50% of patients end up finding out in a hospital when they're acutely sick that they actually have lost all their kidney function and need replacement therapy. And so the one thing in terms of population management is working with primary care physicians and working with nephrologists to do a more consistent check of people's GFR, their kidney function. And there's perhaps a second solution that we've been working on at DaVita, which is we have an algorithm that we use, a predictive algorithm, which takes a bunch of different clinical metrics, and it can predict which patients likely have degrading kidney function. And so we're working with insurance companies on this, which is where we can take a bunch of data from patients that are their members and then try to predict which ones have failing kidneys and then reach out to them to make sure that they go get their GFR taken.
A lot of these medical centers today are starting to adopt a philosophy of coherent prognosis. I know the Mayo Clinic does that. If you go in there, they'll surround you with several different thought leaders and physicians and to try to determine what your situation is. I would imagine that with chronic kidney disorder, there's a variety of other chronic conditions. Who owns all these chronic conditions? Do you just specialize on the kidneys, or how do you bring a different view into taking care of these patients that may have many comorbidities associated with their kidney concerns?
Yeah, you're hitting the nail on the head, Bob, which is a typical end-stage renal disease patient has 5 to 6 chronic conditions.
Wow.
It's unheard of to just have end-stage renal disease. It's typically diabetes and hypertension are what lead to end-stage renal disease. Over 50% of our patients have diabetes and hypertension, and then on top of that, other comorbid conditions. And so one of the things when we talk about bringing better care to kidney care patients, it's about value-based care and entering into arrangements where we believe when we have patients that are coming to our dialysis centers 12 hours a week, or the home dialysis patients where we have home remote monitoring telehealth with them, that we're very well positioned in order to manage all of the chronic diseases that they have. And in fact, we've been doing a lot of that, and the outcomes have been fantastic in terms of the amount of reduction in total cost of care and hospitalizations, as well as better quality of life that we've been able to deliver for those patients under value-based care arrangements.
Well, I know a lot of the medical areas are looking at value-based pricing and all kinds of ways to have bundled solutions, drive efficiencies into that, and make the best practice start to surface and become very real. So you guys at DaVita, when you stop and you mentioned a minute ago that you have some algorithms and things of that nature, do you use any type of predictive analytics at all in what you do and try to coordinate and develop this care model?
Yes. In fact, I think that's probably been one of several really big step changes in kidney care over the last 5 years, and that's the availability of data. So we're fortunate at DaVita because we have over 1 billion data points that we can use on our patients from our dialysis centers in order to drive the creation of these predictive algorithms. And so we now have over about a dozen predictive algorithms that can help us really focus in on the care model and focus in on the patients that need the dedicated resources more than perhaps others do. And so just an example of some of the predictive algorithms that we run in these value-based care population management models of care is, we can predict pretty well now who's likely to be hospitalized. We can predict very well now which CKD, the early stage kidney disease patients, are likely going to end up with end stage renal disease in the next 18 months. There's a model that shows, Bob, your kidneys are likely going to stop functioning, and so we can smooth that transition better. And then there's a bunch of others that we run in order to focus the care models.
Boy, that's so much better than saying, I don't know, we'll just wait and see, actually for the patient experience to have informed direction at least so they can prepare and allocate. And I'm thinking of the families that are involved with this as well. It's just not the patient, but this impacts, I'm sure, a broader base of support people that are involved with it. I was talking about that Mayo Clinic model, and in your care model that you have, how many people participate in that circle of care? You don't just have a physician. Tell me more about that, because I think that might be a value add for our audience.
Yeah, maybe a couple of things. One is, in terms of how we think about the model of care, we do believe that nephrologists are critical to the model of care, both for end-stage renal disease patients as well as the earlier stage chronic kidney disease patients. And so we work very hard to partner with nephrologists. And we have relationships with over 8,000 nephrologists around the country now. We started a new alliance called the Nephrology Care Alliance, where we have over 1,200 nephrologists who have signed up to both take advantage of some of the capabilities that we built, such as the predictive algorithms that I just described, because those are quite helpful to a really very busy nephrologist who needs to focus his or her time. Having predictive algorithms is quite useful, as well as a bunch of education tools that we have. And so that partnership is critical. And then we have health systems that we partner with around the country that are critical to managing the care, kind of the journey, because a lot of our patients do end up in the hospital. And then finally, I'd say critical partners in this are the insurance companies, both commercial insurers for commercial patients and Medicare Advantage, as well as the government. 90% of dialysis patients in America are insured by the government, either through Medicare or Medicaid or other government plans. And so the government is a critical partner in managing kidney patients.
So if I was a patient right now under these circumstances, would I have like a pharma, a doctor, a social worker, a whole variety of other behavioral health people? Are they all part of the solution that you bring into the individual on the personal side?
Yes, and Bob, let me try to differentiate for you the type of care. So Under the status quo, sort of old fee-for-service system, you'd have more siloed, fragmented care. But let me sort of describe the type of care that you might have under a value-based care arrangement. And one way to bring this to life is just a story of a patient under a value-based care arrangement with their insurance company. We'll call him Daryl. So Daryl's a dialysis patient, and he also has a comorbid condition. He has COPD.
Okay.
He needs oxygen, so he carries around an oxygen tank, and he would miss his dialysis sessions quite frequently. And when you miss dialysis sessions, is actually a predictor of mortality and morbidity. And one of the key reasons for hospitalizations in dialysis patients is fluid overload. So you need to do dialysis to take the fluid off. And so because he was under a value-based care arrangement, one of our care coordination nurses decided to go visit Daryl at his home. And turns out that Daryl lives in an apartment on the fourth story of an apartment building with no elevator. Oh. And Daryl explained that the oxygen tank was heavy. And when he woke up, there were days when he woke up and just didn't have the energy to walk the tank down 4 flights of stairs to get to his dialysis session. So he chose not to go to dialysis. And so the nurse worked with Daryl and his insurance company to get a lighter, more mobile oxygen tank. And of course, it solved the problem. And Daryl started being more compliant. He was healthier. His hospitalizations went down. Total cost of care went down. And of course, his quality of life improved.
That's amazing.
So those are the types of stories that are just, when you hear those real personal stories of how you can impact a patient's life just by taking the time to understand what they need, patient-centric, it's quite encouraging to say this is absolutely the right direction that we're heading in.
Yeah, there's a lot of people that are looking at the social determinants of healthcare, some of the basic things that we all take for granted, having access, transportation, good food, the right kind of place to live, et cetera. So it's interesting, Misha, I had a student, one of our adult doctor students, and she donated a kidney to her son. He was an 18-year-old and he needed a kidney. And to her, it was like, no big deal. I mean, I think it's a big deal, and every now and then you see somebody on television talking about their, just their gift to somebody else. They don't even know them. And that took place. So is there a coordination of education regarding transplants? I was interviewing a transplant center a while back, and they said that, there are such thing as living donors, and kidney donations are living donors. So what's your perspective on that, and what role does DaVita have in making people aware of those things?
I think education is absolutely critical for kidney patients, not only for transplant, but more broadly, just to educate patients on their modality choices and what their lifestyle choices are going to be. Kidney diets are really, quite complicated and narrow, and so education around diet is very critical. And so specific to transplants, we do have an education module called Transplant Smart that every one of our patients now gets to run through when they start dialysis. And Transplant Smart is part an education just around that modality and what it means to get a transplant. It's part an organization expert because there's a lot of things that you need to get ready in order to get onto the transplant list. And then part of it is inspiration and just showing other patients who have gone through a kidney transplant and giving patients encouragement that, yes, you can get yourself on a transplant list. And yes, it may take a couple of years to get there, but it's well worth your time and well worth your dedication to remain on that transplant list. And then in terms of, living donations, part of the education is just some really inspiring stories of people using social media now in order to find living donors that are good matches and trying to figure out how you might, the organ networks now do the exchanges of organs. And so part of it is just helping patients understand that they might be able to do that as well.
That's really a positive utilization of social media. It really, like everything else, the internet's got good and it's got bad, and some of the social media. Being out there in Silicon Valley where technology innovation is abundant, are you using wearables and other devices in your initiative to help these patients be informed and gather data and things like that? Or is that too much of a stretch for what line of business you're in?
No, we've been working a lot, especially with our home dialysis patients. We work quite a bit on home remote monitoring devices.
Okay.
So that we can understand what our patients, for example, what their weight is between sessions, and then monitoring some of their diabetes and hypertension in a remote way. And so that's probably the place that we're focused on the most, because we only see those patients probably about once a month. If they don't have complications when they come in for their checkups. And so that's where we're using a lot of technology to stay connected with those patients and help them with their care journeys.
Very good. Well, this has been the most interesting discussion. I think our audience is going to benefit from this. I'm amazed at the approach that you've taken, such a holistic approach, really bringing in more and more ideas and innovation and really becoming customer-centric. The experience of the patient is really, it seems to be at the center of what you're doing. You're trying to bring value, not only in your process, but more value to their lives as well. So any closing comments that you would have to encourage people or direct them to help your cause?
Yeah, maybe I'll end by saying we're really excited about this transformation, if you will, where it's not just about dialysis, but it's about managing patients and bringing awareness early in the care journey, and then helping them throughout their care journey, and doing that alongside with nephrologists, health systems, and our insurance payer partners. And so the more we can do value-based care, in my opinion, the better everyone's going to be.
Well, Misha Palecek, so good to have you on our podcast here. And we look forward to keeping in touch with you and staying tuned in to what you're doing there with DaVita. Thank you very much for being with us today.
Thank you so much, Bob. Appreciate the conversation.
Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode links, notes, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jundal.utdallas.edu and then search under the Center and Institutes tab on the navigation menu. Also, we want to hear from you. If you'd like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z. And let us know how we're doing. I'm your host, Dr. Bob Kaiser, with the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.